Our second presenter will be speaking on analysis of a prospective multidisciplinary management strategy for heterotaxy syndrome with intestinal rotation abnormalities. Our presenter is Grant Collins, a medical student from the University of Arizona in Tucson who is working with the University of Arizona in Phoenix on this project.
Good morning, and thank you for allowing me to speak today. I have nothing to disclose. Heterotaxy syndrome is a complex diagnosis where these patients require care from a number of subspecialties. And because of that, it's important to keep these subspecialties involved in speaking with each other. And so at Phoenix Children's Hospital, these subspecialists got together and they include pediatric surgery, cardiothoracic surgery, cardiology, radiology, and neonatology to create a multidisciplinary management pathway to best care for these patients with heterotaxy. So that starts with the diagnosis of heterotaxy, which occurs shortly after birth, and this is accompanied by an ultrasound to better characterize the abdominal anatomy. From that point, symptoms guide management. If the patients are symptomatic with feeding intolerance, they will get an urgent or emergent upper GI, and if there is a volvulus, we'll proceed to emergency surgery. If there is an IRA, there will be planned surgery to evaluate for the cause of the feeding intolerance, place a G-tube, potentially a laparoscopic LADS procedure. If these patients are asymptomatic, they're tolerating their feeds, they're stable from an abdominal standpoint, that upper GI can be held until they're more stable from a cardiac standpoint. And even if intestinal rotation abnormality is seen on that upper GI, surgery will only occur if the patients become symptomatic, and they will be followed every 3 months for the first year of life, and then yearly after that. So patients were prospectively enrolled. We were able to enroll 18 patients, had an average follow-up of 3.7 years. Important to note that there was a predominance of Hispanic patients, which is an association with heterotaxy that has previously been reported in the literature. 16 patients survived and 2 passed away during the course of the study. This was not due to their intestinal anatomy, but rather cardiovascular complications in one and stroke in the other. So what we found, really as expected, was that most patients are asymptomatic and are not going to require abdominal surgery. There are some patients who are going to be symptomatic and require a diagnostic lap with G-tube, and others who are symptomatic and are going to require emergency surgery for volvulus. In our study, we had 1 gastric and 1 intestinal volvulus. The unexpected finding here was that ultrasound wasn't really predictive. As you can see, there are a number of different in each category, there is differences in what the ultrasound shows, whether that be an abnormal SMA-SMV relationship, normal or indeterminate. Upper GI did demonstrate IRA in each patient that got one. In group 1, only 10 of the 13 had upper GI, and in group 2, only 2 of the 3 had upper GI. So as far as limitations for this study, it was a small study with only 18 patients, and there was some difficulty enrolling. And then there's difficulty with multidisciplinary care, especially when it's first implemented. This was a lot of different subspecialists coming together, and to take everything that was discussed in the focus group to continue to educate their department, including with changes in faculty and residents to make sure that this pathway is followed. And then radiologic diagnosis was not always as easy as we had thought it was going to be going in, and that can complicate the initiation of the pathway. As far as conclusions, in our experience, asymptomatics can be managed non-operatively, but that non-operative management has to include education about the diagnosis and anatomy, especially as the patients get older with the potential for an abnormal presentation of appendicitis, and need to have ready access to care should they become symptomatic. The involvement of key stakeholders is an important part of the management of these complex patients. So the focus group came together to be able to create the pathway and kept lines of communication open so that they can continue to comment on what they're seeing in these patients and make improvements. And finally, the risk of surgery must be balanced with the benefit, which may be limited. These patients have complex cardiac defects, which make anesthesia a very high-risk thing to undergo. And the benefit of surgery, or at least intestinal surgery in these patients, may be limited with a number that are going to be asymptomatic. Thank you.
This paper is now open for questions in the back there.
Hi, thanks. This is actually a really wonderful study. I just want to point out that when we were doing our study on heterotaxy, The first time I went looking for inclusion criteria on retrospective, I got about 20. And then when we went circly a couple of times to circle in the diagnosis of heterotaxy and pulled it together, we got about 224 patients. So I think that one of the biggest problems of all of the heterotaxy literature is not catching the majority of the patients. And what you did was you caught them. You were catching them up front and following them. And 20 is a really good number for a short prospective study. And I think that if you just keep going with this, your longer term data, looking at things like the complications of surgery like bowel obstruction, which is horribly tolerated in these patients, is going to be very valuable. So I think this is a really well-designed study, and I'm totally okay with that small starting sample size.
Thank you.
Hi, Andrew Zigman from Portland. So thanks for bringing the data to us today. I do have a question about the asymptomatic patients who you're following at 3-month intervals and yearly intervals. How far out are you so far with that data collection to determine what the yield is of that follow-up?
So our average follow-up at this time was 3.7 years. And if I remember correctly, the patients that were symptomatic and had volvulus were presented fairly early and not necessarily later. It was the follow-up just to ensure that there are no later complications.
Well, that's my question. In your follow-up period, have there been any symptomatic patients or any patients who've gone on to surgery for their intestinal rotation abnormalities?
I'm not sure of that. I don't think so.
We await follow-up.
Hi, it's Kathy Van Leeuwen. So no, the patients, once you get out of this first year, that's when it's just almost like the regular Malraux kids. You're going to know within the first year if they need something or not. The ones that we're following that are now 3, 4, 5, 6 years old, they're the same as they were at 1 and 2. They're tolerating their feeds. Yeah, they have an IRA, and we're nervous about it, but we're just following them.
I have a question for you. Do you worry about those patients in follow-up when some of the patients in your different locations where you practice in your state can be hours from care?
Yeah, absolutely. And that was something, with managing the asymptomatic patients, access to care is huge. Arizona is a big state, and there's a lot of, we have concentrated population, and there's a lot of rural areas. So it's definitely something to worry about. And I think potentially the advent of telehealth or the increased prevalence of telehealth can help with that. And they also have other appointments with their other subspecialists, and having them be involved with the pathway allows them to potentially alert general surgery and to screen for these things as well.
Yeah, hi, Tony DeRoss from Cleveland Clinic. I'm just wondering what you considered an IRA. Was it all abnormal duodenal junctions, or did you consider things like duodenum inversum and those sorts of things, or what fell into the classification of an IRA?
So it was everything. These patients have such variable anatomy with differences in LAI versus RAI. And so we're pretty broad in our inclusion criteria for what is an IRA.
I also have a question. So in these asymptomatic patients, all of which were managed non-operatively, then what do you think about perhaps not even doing an upper GI in that patient population?
I think it's a good thing to consider. I think at least for the initial study, having it was important just to know that, these patients that are asymptomatic, they actually do have intestinal rotation abnormalities rather than patients that didn't actually develop them. So I think having it initially was important, but maybe something to consider not doing going forward given the results.
Thank you so much.
Thank you.